Hey everyone, and welcome to the training for IV titration. IV titratable medications are a list of medications where we increase or decrease the dosage within a specific range to obtain a desirable measurable response, checking the patient's status using different types of parameters. Here are a list of some parameters, some examples. For our heparin drip, we're going to be checking our anti-XA lab values or PTT. These lab values are ordered every 6 hours, or if you get two lab values within the therapeutic range, then we check it daily. We have our sedatives such as propofol, Precedex, or fentanyl, where we use the raw score. Richmond agitation sedation score is to be added in your work list and used for either pain or sedation. It must be indicated in our documentation. Our cardism drip is to maintain a heart rate usually less than 100 or whatever the physician has indicated within the order, but we must be obtaining our vital signs routinely. Our insulin drip requires a routine check of our blood glucose, where our vasopressors, which should be in a central line, are checking our MAP and blood pressure. All of our titration orders must include our medication name, the correct medication route, our initial starting infusion rate, the incremental units in which we're going to increase and decrease, whether it be milligrams, mics per key, the frequency of how often we're increasing or decreasing, the max rate on which we're going to stop and get our desired effect. So I need to have that target goal. Some medications are going to have a bolus required or not required, or indications and directions on how we should wean the patient off of it or taper them off. When you scroll below, you're going to have a link to access all the titratable medications you can give in your unit, whether you're the ER, CVICU, or any critical care unit. You can see all the medications and the protocols and policies for this facility. Here are a list of the step-down medications such as amiodarone, cardizem, dopamine, lidocaine, cardine, and nitro. Here is just a quick snippet and snapshot of the medications you can give in the critical care areas. There are a lot more, so please take your time and click the link and review the medications you give on your unit. Some important things to keep in mind when attempting to reach our goal for titration is if we've maxed out on a medication and we have not achieved the goal, then we must contact the physician immediately to get an alternate medication. Now, it is important that we communicate with our physician because we don't want to be working outside of our scope of practice. What does this mean? Well, let me give you an example. If a physician tells you to start the medication at 20 milligrams an hour, but the order says 5 milligrams an hour, then unfortunately we're put in a position to make dosing administration changes, and that is not in our scope of practice. So we're put in a bad spot. We must be following the orders of titration that the physician put in place in Meditech. So if that is not accurate, please contact your physician immediately. So let's take a look together at this cardizem order. If you look, the titration is to start at 5 milligrams an hour and to be titrated by 5 milligrams an hour every 10 minutes to achieve a goal heart rate of less than 100 beats per minute. Our max is 15 milligrams an hour, and here it shows some cautions to hold the medication if our heart rate gets down to less than 50 or a systolic blood pressure of less than 90. So let's take a look at this documentation together. What stands out to you? Well, to me, at 8 o'clock, we started at 10 milligrams an hour, which we should have started at 5, as indicated in the order. We should be increasing by 5 every 10 minutes. But here, as you can see, it was every 30 minutes, 15 minutes, and then eventually 10 minutes. We did eventually increase by 5 milligrams an hour, as indicated in the order. This is our max, so we continued it at 15 milligrams an hour until we achieved our goal of a heart rate less than 100 beats per minute. Although we did get the targeted heart rate, this is an example of what not to do. This is not the correct way to document. The last thing we're going to talk about in our parameters is our observation tools for pain. When treating pain, it's important to speak to the patient if they could verbalize how their pain is so they could describe it. If we're unable to use a 0 to 10 numerical rating, then we have other options like a Wong-Baker, a FLAC, but for critical care and ED, we want to make sure that we use a CPOT tool. So the CPOT tool is geared for critical care and giving you a little bit more of the patient. If the patient is sedated and intubated, we could see off the facial expressions, the body movements, the muscle tension, and then the last part will go if the patient is compliant with the ventilator or not compliant with the ventilator. Assessing for compliance with the ventilator is simple. We want to check to see if the patient is coughing, spontaneously coughing and setting off some alarms, or continuously fighting the ventilator and having alarms activated constantly. If the patient is non-intubated, then we're going to check for vocalization, seeing if the patient is making any sound, sighing and moaning, or crying and sobbing. CPOT gives us a better picture of the patient when we're assessing for pain. CPOT is a preferred tool in the critical care areas, where FLAC is most likely used for pediatrics and Wong-Baker as well. You can use it, but CPOT is the preferred method. In this scenario, you can see that the medication that we're titrating is propofol. It asks if the medication is being administered for pain or sedation. If it's for sedation, I'm going to go ahead and use my raw score as we talked about before. If it's for pain, then I'll be using the CPOT score. My name is Adam Pantoja, your clinical educator, and this concludes our video for IV titration.